Welcome students. Now we proceed on to our next topic in urogenital malignancy, that is testicular tumors. Incidence. The affection of right side is more compared to the left side. 3% will show bilateral affection. Black races are more common than the white. Age group that has been observed is between 15 to 35 years of age group. This is the most common tumor observed in this age group. Again, it is also one of the most curable solid neoplasm in our body because this tumor is existing or occurring in a structure that is lying outside the body. Second thing, accurate tumor markers are available to identify the disease. What are the tumor markers? These are either beta HCG or alpha fetoprotein. Both can be used in conjunction also to identify the tumor. Etiology. Congenital versus acquired. Congenital. Cryptorchidism. When there is an absence of testes in both the scrotum. What can go wrong? There can be abnormal germ cell morphology one can observe. There will be increased temperature which leads to formation of various mutational changes in the germinal epithelium, thus contributing towards formation of testicular tumor. Altered blood supply, endocrinal dysfunction, and gonadal dysgenesis. Acquired. A trauma can sometimes be quite devastating to the testicular region. It can lead to hematoma formation. Hematoma, if persists, can lead to pressure necrosis. The pressure necrosis eventually leads to testicular ischemia, and this ischemic necrosis results testicular atrophy. Testicular atrophy is a precursor for formation of testicular malignancy. Hormonal imbalance between the testosterone and estrogens, and atrophy, which is age related. Pathologically, one can observe various patterns in testicular tumors. Commonest what we observe is classified into seminoma versus teratoma. Urologists classify it as two distinct categories, that is seminomatous germ cell tumor versus non-seminomatous germ cell tumors. For our simplicity, we have labeled it in different headings. Seminoma, commonest, occurring at 40%. This is very important for you to know. Most commonest pathology for MCQ is seminoma, followed by teratoma, 32%. Combination of these two up to 14%, interstitial 1.5%, lymphomas can be observed up to 7%, and other categories 5.5%. There is a classification which has been developed by testicular tumor panel, which differentiates the teratoma specifically into 4 categories. Teratoma differentiated, uncommon type, malignant teratoma intermediate, classified into A and B. This is the most common variant of the teratoma that is observed. Then malignant teratoma anaplastic, also known as embryonal carcinoma, and malignant teratoma trophoblastic. Uncommon, but one of the most malignant neoplasms known to us. So it carries the worst prognosis. Now what is the differential diagnosis of this testicular pathology? Now there are various pathologies one can actually gain in the testicular region. The commonest being a hydrocele. Now a hydrocele can easily be mistaken for testicular tumor, but by good clinical examination one can be able to differentiate between a hydrocele and a testicular tumor. Now what is the main difference? In hydrocele there is a fluid collection. Now because of this fluid collection one can able to demonstrate fluctuation, which is not possible in malignancy or neoplasm. Testicular torsion can sometimes give rise to momentary edema of the cord by twisting, but once we do a Doppler study, we can differentiate between a neoplasm and a torsion. Simple epididymitis, that is inflammation of the epididymis, can also mimic malignancy in an elderly person. Epididymoorchitis, that is the inflammation of the epididymis as well as the testis, can also mimic like a malignancy. Hematoma in a post-traumatic scenario, and very rarely a pyocele. But in this pyocele, patient will have fever, there will be acute pain, which classically differentiates from the testicular pain. because testicular pain is basically a dragging type of pain, not per se due to malignancy. We'll here have a look about the normal anatomy just to focus you more on the different aspects. This is a typical picture everyone knows. This is spermatic cord, testes, epididymis, and there are two important layers. One is a tunica vaginalis against tunica albuginea. This tunica albuginea is considered as a first and most important natural barrier towards the spread of the tumor into the surrounding. That is the tunica vaginalis and eventually into epididymis. So what clinical features do we get with this testicular tumor? Most common is a heavy scrotum. Patient will complain to us that we are getting a feeling of heaviness in the scrotum, dragging sensation because of the sheer pull on the spermatic cord, pain in the scrotum. Up to 30% of the patients will have pain in the scrotum. Then many patients will just complain with something thickened in the scrotum. Once we examine, what we figure out is nothing but a thickened spermatic cord. Then few patients come to us with advanced malignancy and they present to us first with epigastric swelling. Now why this epigastric swelling? Because tumor disseminates into the lymph nodes, and these lymph nodes first become evident than the tumor initiation, that is the tumor primary itself. So this is the secondary coming first into picture than the primary. Then the metastasis to lungs can give rise to cough with hemoptysis. 1 to 5% of the patients can have gynecomastia due to hormonal imbalance, especially seen in a teratoma. This is very important. In teratoma, one can get gynecomastia for MCQ point of view. And hurricane tumor, which is one of the very ferocious and highly advanced and very rapid malignancy occurring in the testes, is associated with again teratoma and not seminoma. Metastasis. These tumor metastasize to lymphatics as follows. Most common epigastric region 38%, followed by mediastinal nodes 15%, both lung fields 20%, and supraclavicular region 7%. Investigations. We carry out routine investigations like CBC, urine routine microscopy and culture to detect any concomitant infection. Renal function tests very important, but in initial stages they are not at all altered. Liver function test to detect about the spread into liver. Tumor markers, that is alpha fetoprotein and beta HCG, are very, very important. Sonography of the abdomen and pelvis is also very crucial. This is basically to detect the tumor load into the lymph nodes, that is the metastasis. Now this tumor load is basically going into the retroperitoneal lymph nodes, which we need to classify and which we need to understand. But USG sometimes is not conclusive for this particular entity, and we have to rely on the CT scan. So CT scan, abdomen and pelvis considered as a gold standard to actually stage the disease. Now here one important feature I would like to mention, that this staging of the testes is done post surgery. Now one needs to understand this scenario very, very clearly, that the testes we need to operate first, that is under suspicion, we remove it and we subject for histological examination, and subsequently we stage the disease. So this is a little weird scenario as compared to other places where we first stage the disease and then offer a treatment. Here it is first we treat partially and then subsequently we go for a definitive treatment. So what do? We first take out the testes from a high inguinal approach. Okay, we call it as a Shivasu's maneuver. In this maneuver, what happens? We do a high inguinal orchidectomy and we subject that suspicious testes for histological examination, and depending on the features that we observe, we stage the disease. Now there is Royal Marsden classification available for staging the disease when tumor is just confined to testes, no retroperitoneal nodes. So excellent prognosis. We have cured the patient by achieving or doing high inguinal orchidectomy. Stage 2, spray to regional lymph nodes, mainly inguinal one, and the deep side, that is superficial and deep portions, and few retroperitoneal. Now lymph nodes less than 2 cm can be 2A, between 2 to 5 cm in diameter 2B, and more than 5 centimeters tumor load is considered as 2C. Stage 3 is spread beyond the retroperitoneal, that is the mediastinal nodes that is crossing the diaphragm. That's considered as stage 3 disease. And stage 4 is extralymphatic manifestation of the disease. Treatment. Now, what treatment? As you are aware that for other lesions we do FNAC. Here we do not do FNAC. Why? What is the reason for not performing FNAC and staging the disease preoperatively? What can go wrong? As you are aware, this tunica albuginea forms a natural barrier towards tumor spread. By putting a sterile needle through this, we are actually causing tumor dissemination. The disease which was initially limited to testes, we are bringing out onto the surface, which we do not want. That is called tumor cells seeding across the line of investigation. That is the FNAC track. So we do not do FNAC for these patients. Now, radical orchidectomy. Now, how it is different from standard high inguinal orchidectomy? In high inguinal, what we do, sometimes we don't actually perform the orchidectomy. We take out the testes, we inspect it, examine it under vision, we cut open it on the convex surface, and we take frozen section for the tissue and identify the type of histology. Sometimes this is showing an aggressive nature of the tumor, in which we have to do a complete orchidectomy, that is climb high and remove the entire side. That is radical orchidectomy. Otherwise, we can just do a subcapsular orchidectomy for a small and well differentiated tumor, that you did not remove the entire testis. Means you have to remove it along with tunica albuginea, but remaining structures can go back into the scrotum. Now, when the disease load is going towards the retroperitoneum, one needs to do what is known as retroperitoneal lymph node dissection. Now, this is very, very important because this disease usually spreads to the retroperitoneum, and surgery is called Whitmore's surgery. But this classical Whitmore's surgery is actually quite morbid procedure because we remove large portion of the lymph nodes that are present in the retroperitoneum. So we do a modified portion where obviously positive nodes are only picked up, like a berry picking. After the retroperitoneal lymph node dissection, though we have done as much as possible macroscopically, still these patients will warrant a radiation therapy because of widespread tumor dissemination into the lymphatic region. So a radiation therapy is must. Here we give basically a teletherapy and not a brachytherapy. And these are again a chemosensitive tumors. So we give chemotherapy. What are the chemotherapeutic drugs available to us? We give vinblastine, we give ifosfamide, and we give cisplatin. Now these three regimes in combination, or three drug regime in combination, we usually give for a period of 4 to 6 weeks at 3 weekly interval, and usually see a very nice prognosis. In very special situations, what we need to do, we subject the patient for autologous bone marrow transplant. Again, it is very important to know that if the disease is very aggressive, then we have to perform maybe a bilateral orchidectomy and not just a unilateral orchidectomy. But for that you have to take a special consent from the patient and you have to explain to the patient. The major problem with this disease is post-surgery, there is a psychological breakdown for the male patient because there is absence of testes in the scrotum, and it is something difficult to understand for a male person. So sometimes you have to put artificial testes into the scrotum just to have the normal feeling for the patient, just to give a psychological boost. That is why it's very important that before you attempt any surgery for such testicular tumors, you need to do a very good counseling. So as to summarize in this, what is important at early diagnosis, correct investigations to avoid FNAC, clinically understand the disease, do a good investigation of a CT scan, and offer good treatment after thorough counseling